Welcome back to MLT 130. Now we're going to cover the lecture outline for therapeutic drug monitoring. So some indications we need to consider when talking about therapeutic drug monitoring is there serious consequences for over or underdosing patients. There's a small difference between therapeutic and toxic ranges. There's a poor relationship between the drug dose or the amount of the drug and the serum concentrations and therapeutic toxic benefits. When there's changes in the patient's physiological state, there may be changes in the concentrations. There may be drug interactions with other medications. And finally, we can use therapeutic drug monitoring to monitor patient compliance or how they're taking or if they're taking their medications correctly. There's different routes of administration for our therapeutic drugs. There's IV or intravenous, there's IM or intramuscular, there's subcutaneous, which is skin or under the skin. There's transcutaneous, which is passing or in or penetration through the skin. There's suppository, which would be putting in the rectum, and there's coarse oral medications. Now let's discuss the absorption of our therapeutic drugs. Most drugs are absorbed in the GI tract in a consistent manner in healthy individuals. Next is the hepatic portal system, and when you hear hepatic, you should be thinking liver. The first pass is metabolism. This is in easy terms means all you ingest, including medicines, drugs, alcohol, toxic substances. Once absorbed from the intestine, it passes through the liver first. The liver has a detox function. This is why often we see that some drugs or medicines or alcohol damages the liver. Other good examples is Tylenol or acetaminophen. Taken over time in high dosages can damage the liver. Now let's talk about the difference between free and bound drugs. Drugs may bind with serum constituents, usually seen in drug protein complexes. Remember, a lot of times things will bind with a protein. Only free fractions can interact with a site of action. Free fraction best correlates with both therapeutic and toxic effects of a drug. So how are drugs and medications eliminated from the body? In general, they're eliminated from circulation through hepatic metabolic processes and renal filtration. So think the liver and the kidneys. All right, now let's talk about the steady state. The steady state is when the amount of drug given is equal to the amount of elimination during a dosage period. It usually takes 4 to 7 half-lives per dose to reach a steady state. And what's a half-life? It's the time taken for the concentration of a drug to be reduced to half its original value. So let's talk about peak and trough levels now. Drugs are administered in a scheduled manner with multiple doses given over a period of time. This manner of drug administration produces high peaks and low troughs, variations in drug concentrations. The aim is to keep the trough level from dropping below a concentration of therapeutic benefit and to keep the peak concentration from rising above a toxic level. It generally takes 4 to 7 doses or half-lives of a drug to reach a steady state where the peak and trough levels can be assessed. The next thing we need to discuss is the actual classes of drugs that we use in therapeutic drug monitoring. And the first class is cardioactive drugs. And the first drug is digoxin. It is a cardiac glycoside for congestive heart failure. It improves contractions. Its serum concentration correlates 8 hours after the dose. Changes in the glomerular filtration can greatly affect the serum concentration. The thyroid effects. Hyperthyroidism causes resistance. Hypothyroidism causes increased sensitivity. Lidocaine is used to correct ventricular arrhythmia, which is abnormal heartbeat, and prevent ventricular fibrillation, which is irregular heartbeat. Quinidine is used to treat cardiac arrhythmias. Procainamide is used to treat cardiac arrhythmias. NAPA, which is another form of procainamide, is a hepatic metabolite which is also used for antiarrhythmic activity. So we must test for both procainamide along with NAPA. The last one in the cardiac category is disopyramide, which is also used to treat cardiac arrhythmia. It is often used to substitute for quinidine. Our next class of drugs is our antibiotics. Our first category in our antibiotics is our aminoglycosides. These treat our resistant gram-negative bacteria. These include gentamicin, tobramycin, amikacin, and kanamycin. All can cause nephrotoxicity and ototoxicity, and they can be given through IV or IM, intravenously or intramuscularly. Next in our antibiotic group is vancomycin. These are glycopeptide antibiotics. They're effective against gram-positive cocci and rods. They're given through IV. They can cause red man syndrome, which is a red rash on the face, neck, and upper torso. It can cause a burning and itching feeling, and it can also cause the nephrotoxicity and the ototoxicity. Our next class of drugs is the anti-epileptic or anticonvulsant drugs. Our first drug is phenobarbital. It's slow-acting barbiturate. It's used to control seizures. Primidone is an inactive form of phenobarbital, and this form is administered when rapid absorption is needed. Primidone is quickly converted to phenobarbital. Some other anti-epileptic drugs include phenytoin, also commonly referred to as Dilantin, and valproic acid, ethosuximide, and carbamazepine. And this one is used less often because of its serious toxic effects. It can cause leukopenia and liver toxicity. The next class of drugs is antipsychotic drugs. Lithium is first. It's used to treat bipolar or manic depression. It is an alkali metal. It has toxic effects and it can impair renal function. Next, for antipsychotic drugs, we have our TCAs, or tricyclic antidepressants. These treat depression, insomnia, and extreme apathy, and there are some examples of our TCAs listed here. The next class is our bronchodilator drugs, and phenolphthalein is listed under this category. It's used for asthma and chronic obstructive pulmonary diseases. It relaxes the bronchial smooth muscle. In neonates, phenolphthalein is rapidly metabolized to caffeine, and both phenolphthalein and caffeine must be monitored. This category is our immunosuppressive drugs. These are primarily used to suppress transplant rejections in our graft versus host disease patients. It's used to prevent host versus graft rejections for all types of transplants. Whole blood is the specimen because 2/3 of cyclosporin is found in red blood cells. Next in this category is tacrolimus. It's 100 times more potent than the cyclosporin. It's less toxicity. It also has less toxicity than the cyclosporin, and whole blood is the specimen of choice. Sirolimus is the last one in this category, and whole blood is also the specimen of choice. Our very last class of drugs that we're going to discuss is anti-neoplastic drugs. These are used to treat various neoplasms such as leukemia, lymphoma, breast cancer, osteosarcoma, and choriocarcinoma. Methotrexate is used to destroy neoplastic cells. It is a folic acid antagonist. It interferes with DNA synthesis in all cells. Therefore, the methotrexate antagonist leucovorin must be given to rescue your normal cells. This concludes our lecture outline on therapeutic drug monitoring. If you have any questions or need any further clarification, don't hesitate to reach out.